Good morning, everybody. I'm so very honored to be here. My name is Kodi Fitzsimmons, and I serve as the Director of Student Affairs for the North Dakota University System. This next chunk of presentation is with Kodi Pinks and Robin Lang and myself, and Kodi and Robin are not here. So, but good news, we do have Kodi pre-recorded her presentation. So we're going to play that now, as long as I can hit play correctly on this. So you'll see Kodi remotely on the screen. And then when this presentation is finished, I'll hop back up here and present Robin's data as well as my own. So here we go.
Good morning. My name is Kodi Pinks. I want to thank you for this opportunity to speak this morning. I am an epidemiologist with the North Dakota Department of Health. What that means is that I collect, analyze, and interpret data. I want to apologize that I can't be there to present in person. So this is a recording of my presentation. And if you have any questions, my contact information will be provided at the end. Today, I'm going to be providing statistics on deaths that occurred in North Dakota. Data is important for understanding the scope and magnitude of suicide in our state. Data can also point to the factors that play a role in suicidal behavior and can make a difference when it is used to determine how to most effectively direct or redirect resources to the communities and populations that need them most. As I go through the data, I want you to all know that the health department and I understand that behind these numbers are people, that their loss has had wide-reaching impacts on their family, friends, neighbors, and communities. The data that I'll be presenting on today comes from the North Dakota Violent Death Reporting System. NDVDRS is a state-based surveillance system that links data on deaths from multiple sources. Some of these sources include medical examiner reports, coroner reports, law enforcement reports, toxicology results, and death certificate information. NDVDRS brings together data on the who, when, where, and how these deaths occur to help us understand the why. The goal is to provide state and local communities with a clear understanding of these deaths to help guide local decisions about targeted prevention efforts and to help track progress over time. Data collection for NDVDRS began in January of 2019. That is the only data set that is finalized and closed, so that is what I'll be presenting on today. But I will be sharing some provisional data for 2020 and 2022. One thing I want to note is that these numbers include all suicides where the injury occurred in North Dakota and is not dependent on North Dakota residency. Therefore, these numbers may not match data provided by North Dakota Vital Records. So in 2019, there was 146 suicides statewide. In 2020, there was 147 suicides statewide, and for 2021, there was 165 suicides. That number is still very provisional. I know there are still death certificates pending, just waiting to be finalized, so that number more than likely may or will change. So from looking from 2019 to 2021, there is an increase of 13% in suicides in that three-year time frame, which is very alarming. This slide is looking at suicides by month, sex, age group, and race. So the top left graph is showing suicides by month. So research on seasonal effects on suicide rates suggests that prevalence of suicide is greatest during the late spring and early summer months, despite the common belief that suicide rates peak during the cold, dark months of winter. But as you can see in 2019, May, June, and December had the highest frequency of suicides. May had 17, June had 15, and December had 14. The graph on the right looks at suicides by sex. Males accounted for 83% of the suicides, and females accounted for 17% of the suicides in 2019. Bottom graph on the left is looking at age group breakouts. The 50 to 59-year-old age group had the highest prevalence at 23%, followed by the 30 to 39-year-old age group at 22%. Just so you know, the average age of death for 2019 was 42 years when you're looking at just the suicides. And then the last graph here is suicides by race. The white population made up 90% of the cases, and the American Indian population made up 6%, and all else was 3%. This is a graph looking at suicide rates per 100,000 population by sex and age group for 2019. The overall suicide rate for North Dakota was 19.2 per 100,000 compared to the U.S. rate of 14.5 per 100,000. Suicide rates were also higher among males than females, both for North Dakota and nationally. The North Dakota suicide rates for males was 31 per 100,000 compared to females at 6.7 per 100,000. The suicide rates, when looking at age groups, was highest among the adults aged 25 to 34 years at 29 per 100,000, followed by the 45 to 54-year-old age group at 26 per 100,000, and finally the 35 to 44-year-old age group at 24 per 100,000. So as you can see, North Dakota does overall exhibit higher suicide rates than the national rate. But if you notice that once you get past the age bracket of 55 to 64-year-old age group, actually starts declining, and North Dakota actually has lower suicide rates than national in the age group of 65 plus. This is looking at suicide rates per race and ethnicity. North Dakota races experienced higher rates of suicide than the national rates for all races except for the Black or African American population, which was pretty close to the national rate at 6.8 for North Dakota and nationally 7. For North Dakota, the white population had a rate of 19.9 per 100,000, followed closely by the American Indian population with a rate of 19.7 per 100,000. Then for ethnicity, both North Dakota Hispanic and non-Hispanic ethnicities experienced higher rates of suicide than the national rates. On the non-Hispanic had a rate of 19.2 compared to the national rate of 16.1. And the Hispanic rate had a rate of 15.9 compared to the national rate of 7.2. This is a graph looking at suicides by educational attainment and marital status. So the graph down the left depicts deaths by educational attainment. Some studies have shown that individuals with a high school diploma and no post-secondary education appeared to be at a heightened risk for suicide, while individuals with a bachelor's degree or higher appeared to be at a reduced risk. As you can see, the prevalence for suicide was highest with those that had a high school or GED degree at 43%, followed by some college but no degree at 19%. Then the graph on the right looks at suicides by marital status. And some studies have shown that higher rates of suicide were found in divorced than in married individuals. Divorced and separated persons, according to the study, were more than twice as likely to die by suicide as married individuals. When you look at our data, at least for a single year of our data, we found that the never married individuals had higher prevalence of suicide than divorced and separated individuals. So never married was 51%. Those that were married or in a civil union or domestic partnership accounted for 23% of the cases, and divorced individuals were 15%. This is a slide that is looking at industry data. So most of this data does come from the death certificate. As you can see, it's circled there on the right. The construction industry had 18% of the suicide deaths in that year. The construction industry is actually the 5th largest sector of employment per industry in North Dakota, and it comes behind manufacturing, wholesale and resale trade, education and health services, and leisure and hospitality. What's interesting here is the national rate for the construction industry is 45.3 per 100,000 males. In North Dakota, the suicide rate is 92.9 per 100,000 males. When reviewing the data, the construction industry suicides tended to happen pretty exclusively in spring to early summer, so March to June. Once we get more years of data finalized, we'll be able to see if this trend continues. Along with the construction industry, both mining and quarrying, oil and gas extraction, and the agriculture, forestry, fishing, and hunting industries exhibited higher rates of suicide than the national average. Another thing I was going to point out here is that in the other services category, that is where current or former military service members are represented. So if you look at that 14% and that particular category, 25% of those deaths were actually current or former military service members. So that is, when you do the calculations, that's about 13% of the total number of suicides for 2019. This slide is looking at suicide by sex and method and age group. So the graph on the left shows the percentages of suicide deaths by method in 2019. The most common means used was firearms at 58%. Among males, the most common methods of suicide were firearms at 62%, followed by asphyxiation at 26%, drug overdose or poisoning at 5%, and all else at 7%. And then when you look at the females, the most common methods used were firearms at 40%, followed by asphyxiation at 28%, and drug overdose or poisoning at 24%, and all else 8%. And this is pretty comparable to what's seen nationally. In 2019, firearms accounted for 50% of all suicide deaths in North Dakota. Just some additional information: approximately 41% of the decedents were the gun owner, and approximately 26% of the guns were not locked, and 12% of the firearms were stored loaded. The graphs on the right shows the percentages of suicide deaths by method and age group. As you can see, firearms was the most common mean used across all age cohorts, followed by asphyxiation. This graph is looking at toxicology results, and it's actually for 2019, 2020, and 2021. You can see the list of the different types of substances at the bottom. Again, not everyone actually had a substance in their system, but this is looking at what was found overall. Some things I want to point out here: antidepressants in 2019 was at 38% of all the cases, and then by 2021 it had decreased down to 28%. That is a 33% decrease from 2019 to 2021. The other thing that was noteworthy was the antipsychotics. In 2019, it was at 5%, and then by 2021, it went up to 11%, which is a 120% increase during that time frame. And the other noteworthy one was the substance of marijuana. In 2019, only 3% of the cases had marijuana in their system, and that had increased up to 17% by 2020 and 2021, which is a 467% increase in that 3-year time frame. The data on the right is looking at the blood alcohol concentration, which refers to the percent of alcohol in a person's bloodstream. Just to put a little more context to this, 0.08% is the current legal limit in North Dakota that is considered illegal and unsafe to drive. When you get up to 0.2%, a person is confused, dazed, disoriented. The person may need help with walking and standing. Blackouts can begin at that level of intoxication. And then at 0.4% or higher, that level may put you in a coma or cause sudden death. So in 2019, almost 50% of the cases had alcohol present in their blood. The median alcohol level was 0.18. And the max alcohol level was 0.8, which is double the lethal limit. In 2020, alcohol present in the cases went down to 29%. The median alcohol level was 0.14, max of 0.42. And then in 2021, 33% of the cases had alcohol present. And the median alcohol level was 0.16 and the max was 0.42. So overall, from 2019 to 2021, the amount of cases that had alcohol present decreased by 33%. So this slide is looking at some of our circumstance data. I want to caution because it's only when circumstances were known or noted in the coroner report or in the law enforcement report. But based on what we have, 30% of the decedents had a history of expressed suicidal thoughts or tendencies. 15% had previous suicide attempts. 26% recently disclosed thoughts or plans to die, and 38% left a suicide note. When we look at whom intent was disclosed to, 53% was to a previous or current intimate partner, followed by other family members at 27%. This is another side looking at some more circumstances. On the left, that column is looking at economic circumstances. So approximately 22% of the cases had a contributing civil and or criminal legal problem. 20% had a job problem, 16% had a financial problem, 7% were either evicted or lost their home. The middle column in red is looking at some more of the mental health circumstances. 47% had a current diagnosed mental health problem. And when we looked at what kind of diagnoses there were, depression was the most common, followed by anxiety disorder. 46% had a current depressed mood, 43% at some point in their life had been treated for mental health or substance abuse. And then the last one in red is 27% currently were receiving treatment for mental health or substance abuse. Then the column on the right is looking at social circumstances. 41% had an alcohol problem. So if you remember, in 2019, over half the cases had alcohol in their system. 38% had an intimate partner problem. 22% had some other substance abuse problem, and 18% had family relationship problems. This slide is looking at our syndromic surveillance. Or the next few slides, we'll look at our syndromic surveillance. This is a surveillance system that consists of emergency department, urgent care, and walk-in clinic visit information for 2017 to 2021. This information is completely de-identified, but it's really good for tracking trends and patterns. So this, the data comes from hospitals in the state, and that includes all our acute care and critical access hospitals. There are some caveats to this data. When I talk about the numbers, those numbers represent a syndrome. And what that means is that a syndrome is one that utilizes both ICD-10 codes and chief complaint codes, which looks for keywords. These are not considered a true number of cases because syndromes may contain noise and may actually include non-related events. Just for instance, I was looking for firework injuries this summer, and it pulled in a case that mentioned a fire department was responding to the scene and had nothing to do with actually fireworks. So some of that may exist in the data set. Another caveat is that not every hospital submits both ICD-10 and chief complaint, so visits may be missing, and some hospitals only submit data on North Dakota residents, therefore underestimating the impact. So the first syndrome I utilized was suicide ideation syndrome. That is from CDC. They built this query, and what it looks for is visits related to suicide ideation or thoughts or plans of engaging in suicide-related behavior. The second syndrome, also created by CDC, is the suicide attempt syndrome, and that looks for visits related to suicide attempts or self-directed and potentially injurious behavior with an intent to die as a result of the behavior. Here are the numbers from 2017 to 2021. The red line is suicide ideation. So in 2017, there was 4,793 events, and by 2021, it had increased to 5,966, which is an increase of 24%. The blue line is looking at suicide attempts. In 2017, it was 1,170 events, and then it increased to 1,469 in 2021, and that again is an increase of over 26%. This is looking at syndromic suicide ideation events by sex. Females accounted for 54% of the visits, and males accounted for 46%. The group with the most suicide ideation related events was the 10 to 19-year-old age group at 25%, and then followed by the 29-year-old age group at 23, 30 to 39-year-old age group at 18, and it just continues to decline from there. So you do see a decrease in suicide ideation events as age cohorts increase. This one is looking at suicide attempt visits. So those majority were female at 63%, and males accounted for 37% of those events. And then again, the age group with the most suicide attempt visits was the 10 to 19-year-old age group at 36%, followed by the 20-29 at 25%. One thing I do want to note is that when I compared this number to last year's numbers, so 2020 data, we actually saw a 10.3% increase in the 10 to 19-year-old age group as it relates to suicide attempts compared to what we saw last year. So that 10.3% increase is alarming. This is a heat map, which is a data visualization tool that shows magnitude of an event in color dimensions. And the variation in color provides visual cues to see how the event is clustered or varies over space. This heat map displays suicide ideation events by county for the years of 2017 through 2021. And as you can see, based on the coloring, the dark colors represent counties with higher rates of suicide events. This is based on where the patient lived, not necessarily where the patient was seen. So Ward County had the highest rate at 1,232, followed by Benson County at 1,206, and Montreal County at 1,123. This is the same thing, but it's looking at suicide attempt events by county. Benson County had the highest rate at 629, followed by Montreal County at 360, and Sioux County at 355. I want to give a special thank you to these individuals. They either helped the program directly or they have helped with some of the data analysis that you saw today. I can't do it without them. And of course, a big thank you to Dr. Tracy Miller, our state epidemiologist, who made applying for this grant possible, and her leadership also helps improve this program every day. So in closing, when it comes to being actionable, timely data is important. It doesn't help to learn about an issue a year or so after it has happened. We need to be responsive to what is happening now. And given our many challenges, we must be more innovative about collecting, sharing, and using data to improve outcomes. So if you have any data needs or questions about anything I presented today, please feel free to reach out to me. And you can see my contact information on the slide. Thank you.
All right. Thank you so much to Kodi. We are very bummed out that she couldn't be here today with us. And so this section of the program, like I said, so Kodi's supposed to be standing here on my right. Robin Lang is supposed to be standing here on my left. Robin Lang, the Assistant Director of Educational Improvement and Support with the Department of Public Instruction. And then also sort of an 11th hour add-on, Faye Seidler, who's the founder and clinic administrator of Harbor Health Clinic in Fargo. She provided some data regarding the LGBTQ plus youth in the state. And so I'm going to I threw a couple of her slides into my presentation as well. So I'm putting on my first hat. I'm pretending to be Robin Lang right now. So let me jump in. So this is going to be from the perspective of the K-12 realm. So some of the things that Robin wanted to talk about in her presentation was the YRBS, the Youth Risk Behavior Survey, and all of the great numbers that we get from that. And then I'm going to touch a little bit on sort of that multi-systems approach that's happening in the K-12 system across the state. I'm going to go into phase data, and then I will go into what we're talking about in the higher ed realm. So I work with the system office, with the university system, so I'll be able to sort of give you an overview of what's going on across all of our 11 state colleges and universities. So one piece that Robin wanted to start out with was looking at Governor Burgum's strategic initiatives, which were established, well, when he first came into office in 2016 and then sort of solidified in 2019. And one of the 5 main areas is behavioral health. And of course, we need to have the statement said that behavioral health is health. Health is behavioral health. But when we're really talking about behavioral health, we're really talking about what encompasses our physical and emotional well-being, that focuses on choices and action that affect wellness. So behavioral health, it's grounded in prevention and early intervention, but it runs the whole continuum of care all the way through treatment and recovery. So behavioral health is often used to describe the connection between our behaviors and the health and well-being of the body, mind, and spirit, your eating habits, your drinking, how much you exercise, and how those either immediately or over time impact your overall physical or mental health. So in looking at the governor's goals of behavioral health, it certainly always helps you as a state agency or an organization to then bolster what you're doing if you've got the governor and the first lady behind you, right? So the Youth Risk Behavior Survey has been around since the 1990s. We've been doing it in North Dakota since 1995. So it's completely voluntary, completely anonymous. So it's students in grades 7 and 8, and then also in high school, the 9 through 12. And they do it every other year in the spring of odd years. So they did it in 2021. We don't have the 2021 data just yet. So I have the 19 numbers to show to you. But the great thing about surveys is they really do inform your programming. They inform how you're going to approach issues. And then you can really see what it is that's going on in your own school system. So the YRBS The whole survey does all kinds of things. They ask questions about alcohol, tobacco, and other drugs, sexual behaviors, dietary behaviors, physical activity, and of course, unintentional injury and violence, suicidality, which is why we're here today. So one of the handouts on your table, this one here, this one is from Robin. It's nice and colorful. It's got some cute dot lines here for you. I don't have anything as cute and lovely as Robin's stuff, of course, but when you look at that, and here the slide up here, or the slides here, the slide on your left is the bottom slide, and so those are for your middle school students. The top one on your sheet of paper is the one on the right, that's high school students. So you can see where those numbers are. That top dark blue line is the percentage of students that felt sad or hopeless for 2 weeks or more, so much so that they stopped doing some of their usual activities. Now, when I get into my data from the higher ed side, you're going to see how much those numbers went up between 2018 and then when we polled students in 2020, when we were 7 months into the pandemic. Obviously, there's a lot more challenges. I don't need to say that to anybody here, but when we see that steady line creeping upwards for all of the age groups, the amount of sadness and hopelessness that students are feeling is real, it is palpable, and it is growing. That next line down, that green one, are this percentage of students that seriously are considered making a suicide attempt. The next line down, the red one, is that they made a plan about how they would attempt suicide. And then that bright blue line is the percentage of students that did attempt suicide. So for middle schoolers, you're looking at around 10, 11%, somewhere in there. And then for high school students, around 11 or 12%. So what are we doing about this, right? How are we addressing this? There's schools, of course, that are doing things boots on the ground, but we do have legislation in motion. A couple of years ago, we had a great student speaker, a young woman named Kennedy. She had survived and thankfully was never completed a suicide, but she was very instrumental in getting a state law passed that requires a minimum amount of 8 hours of education to all professional staff in elementary, middle, and high schools regarding mental health, and most notably about suicide prevention, how to recognize signs, how to intervene, and so that has been very instrumental in our schools. And then the two other pieces of legislation, items 2 and 3 here on this slide, a lot of words, I know, but they really have to do with the Behavioral Health Resource Coordinator. So in 2019, that there would be, every school district would designate a Behavioral Health Resource Coordinator. And then the second part of it was a different Senate bill that provided more resources for that resource coordinator through the Department of Human Services and their Behavioral Health Division, who was our lovely sponsor and got Dennis here today. So it just really goes to show it takes everybody, right? It does take a village. That why is anybody reinventing the wheel when we know the Department of Human Services has wonderful resources and wonderful tips and tricks to share with everybody. So we're directly looping them in with the K-12 system and getting students, faculty, and staff the resources that they need. So there's many different prevention resources out there. A couple of them have already been mentioned. We, of course, love Sources of Strength, developed here locally. It's a wonderful worldwide, world-renowned program. A Safe Talk, that QPR, that question, persuade, and refer was already mentioned. All wonderful, great prevention resources. I'll also give a shout out to Mental Health First Aid, one of the bottom ones listed on the evidence-based programs and trainings. We have in the North Dakota University system, we have a handful of trainers that provide the mental health first aid training. It's essentially like a bystander training for mental health. And what I mean by that, if you're not familiar with the term bystander training, is it's really about how can you, an everyday person, right? How can you tell that maybe someone is in distress? Maybe someone's having a panic attack. Maybe someone's starting to feel overly anxious. What are some things that you can do as just an everyday person that is empathetic and cares about people around you? How can you get them help? And what can you do? It's a great course. It was an 8-hour course, and they have some other smaller ones. They have some that are designated and more geared towards youth. And it's a great program. I recommend that you check it out. And of course, there's tons of tools, resources, all kinds of toolkits and guides that are available to everybody as they start to tackle all of this. So that is the short of the long of what Robin Lang was going to say. She was going to say it probably a lot nicer and a lot more cheerfully. She's a wonderful, wonderful person. So I'm going to go into Faye's data now. And so Faye has put together this incredible community uplift report. So it is the North Dakota LGBTQ plus school climate report. And this is really an incredible thing. It's around 40 pages long. And it's fascinating, and it's very troubling in that she developed this report by looking at school policies that exist across North Dakota, by looking at the YRBS data, and Faye connected all of that to national policy on data outcomes to make meaningful comparisons between the outcomes of our queer youth and the policy impacting that. So some of the things Faye provided a couple of highlights, a couple of bullet points, since Faye wasn't able to be here to present, that 84% of queer youth do not turn to adults when they're feeling sad, empty, hopeless, anxious, or angry. And one affirming adult can reduce suicide attempts by 40%. And that to me is just so profound. Just one person that cares, one person that a student can reach out to can reduce up to 40% of suicides. And as you can see in our LGBTQ plus community, the suicide rate is absolutely heartbreaking. That when you break down that YRBS data, so this wonderful graph from Robin, when you break that down, and if we were to break it out by gender or by age or whatever, but when you break it down by straight students and queer students, if you are a member of the LGBTQ plus community, you are 4.5 times more likely to attempt suicide than any of your straight or heterosexual counterparts. So those that are seriously thinking about suicide, the comparison is 19% to 61.6%. Those that make a plan, 13% to nearly 50%. And those that attempt suicide, 7.4% to 33.3%. So Faye really asserts that if our suicide prevention efforts do not target queer youth, and if we don't understand the specific issues that impact and increase suicidality within this community, and if we don't address the queer phobia or transphobia in our systems, then we will do nothing to reduce these alarming numbers. And so this is all about, really, we don't want to leave anybody behind. It's very important that we try different strategies that are going to reach different groups of people. There's no one size fits all, but like I said in the previous slide, that one affirming adult, just one more adult, that can save a life. It can save 40% of the lives. So that is Faye's soapbox, and now I'm moving on to my own. So welcome to the North Dakota University system. So when I'm talking about the North Dakota University system, I'm talking about the 11 state colleges and universities that are operated under the guise of the State Board of Higher Education. In addition to our 11 state schools, we're at one of them right now, there are 5 tribal colleges and 3 private institutions in the state. I like all of those people. I think they're great, but my data does not reflect any of those schools. This is just the group that I work with under the State Board of Higher Ed. So once you get into college, we no longer do the YRBS. We do a survey that we call the ND SWAPS, the North Dakota Student Wellness and Perception Survey. We've used many system-wide survey tools over the last 20, 30 years. And so we've always focused more so on looking at that alcohol and other drugs use, and then started factoring in and asking more about sexual assault or things that impact students that way. But in the last 4 years, starting in 2018, we changed up the survey entirely thanks to some very dedicated researchers and professional staff that we have across the state, including Dr. Jane Vagnis-Frisch at the North Dakota State College of Science. And so we revamped the survey to really look at wellness, to ask about mental and behavioral health, and to really see what's going on, right? So these are just some stats about the survey that we sent it across all of our 11 institutions. We do it in the fall of even-numbered years, so we're starting preparations now for the 2022 survey, which we'll do in October, November of this year. We got around an 11-12% response rate, not 100%, obviously. We'd love to get that. Anything over 10% is gravy for us as far as validity of data. We'd love to hit the 20% mark, but it's difficult to get people to do surveys, right? And then the last data point that I really just want to point out here on the bottom of this, the last bullet point here, is that it's around 93% of our students, 94-ish, report having some form of health insurance, whether that's through their parents' plan or they're independently insured. And like Cora talked about in her opening remarks and that Dennis touched on too, I just bring that up in that is just a point of access. If you have health insurance, some of them will cover some mental health services, some of them don't. But if you don't have any health insurance, it's most definitely not covered. So going back to what is in this survey, again, we're still continuing to ask questions about alcohol, tobacco, and other drugs. We ask students about their perceptions of alcohol, that how many students do you think are drinking on any given night? Or how many students do you think are using cannabis recreationally? And you'd be shocked. Everyone thinks everybody's doing it, when in fact, not everybody's doing it. So this is a really good wake-up call to students. Again, that perception of what's going on social media versus what is actually happening. We asked them about sleep. I used to be a residence hall director at a couple of different universities, and if I ever had a roommate conflict, the first question I would ask is, well, what time do both of you go to bed? And chances are they slept differently. One wants all the lights on and wants music on or sleeps with the TV on, and the other one is like Dennis, needs the darkness, needs the mask, needs the noise canceling headphones. Because if you're not sleeping well, you're not living well, right? So we ask about sleep, we ask about their experiences with sexual assault, and we of course asked about the behavioral health and well-being and their suicidality. So since 2014, so in the last 8 years or so, depending on the campus, we've seen anywhere between a 20 to 50% demand increase for counseling services. And so as you cook down this slide, 6 of our campuses have 1 counselor available to students. 1 has 2 counselors available, and 3 campuses have 3 or more counselors available. So when you do that math, 6 plus 1 plus 3, that's 10. And we have 11 institutions. So one of our campuses right now does not have a mental health provider on campus, but again, it takes a village. They've got a wonderful relationship with a local provider. They refer students off campus. It can get a little bit clunkier. You don't have someone right there, but it's working as well as it can right now. We need more mental health counselors. We need more licensed addiction counselors. We need more social workers. We need more people in this field. And so it can be hard to find somebody in all of the towns where we have institutions for someone to be able to work in this role. So to meet those needs, we also have telemental health services available. We have a great relationship with Northern Prairie Community Clinic in Grand Forks. So they are a sliding scale clinic. They're open to the community, but they also provide telemental health services. And so there's always a handful of students across the system that will choose to use those services. There is, of course, the betterhelp.com and all of the apps that are available that we know that quite a few students do utilize. So if you're not feeling great and you're not sleeping great, how are you doing in the classroom, right? So from the university system's perspective, I mean, we want all of our students to succeed. We want to retain all of them. We want to graduate all of them. We want to keep them here in the state to work forever, right? We want them here. So every single campus has an accessibility office. So that's going to help students that need any type of accommodation in the classroom, whether they have a vision impairment, an intellectual or physical challenge, or if they have an emotional need, such as anxiety, you have test anxiety, you have attention deficit issues. So on the K-12 side, this would be accomplished through an IEP. You don't have IEPs once you get to college, but you can work with an accommodations officer who can get you set up, right? So this is just a snapshot of one of our campuses. So I pulled the data from every other year. So in 2014, the amount of students that came into their accessibility office, 25% of them had needs on that emotional spectrum. Test anxiety, PTSD, bipolar disorder, you name it, right? And 75% were those that were hearing, vision impaired, physically impaired, intellectually impaired, dyslexia, those types of things. Well, as you travel through time, the scale starts to shift, right? So here we are, the 2020 data, 6 years later from 2014, it's nearly completely flip-flopped, that 70% of the students coming in for accommodations have emotional needs and 30% have those intellectual and physical needs. Now, the reason why I point this out, and my husband works for the fire department here in town. He's a little bit more rough and gruff than I am, so I'm the snowflake, right? And he's more of the snow plow. But when I point this out, he would say something like, "Oh, it's the softening of America's youth," or something like that, right? And that is not what this is trying to illustrate at all. What this is illustrating is that students that have needs that are unseen can still receive services and still be successful in the classroom. That's what this says. So I get really emotional when I talk about that, but it's really important that students know that when they're in high school and they're on an IEP, they can go to college. You can still make this work. We have professionals that want to work with you. We have faculty and staff that truly care about your success, and they want to see you in those classrooms. So if you're one of those students that is like, I'm just barely making it now in high school and I have to do it with all this help, there is still help available and you can do well. So back to the ND swaps, back to the data. So I just have, because we developed the ND swaps in 2018, I don't have as far-reaching data as Robin does all the way back to 2009 on her YRBS, but just the difference, of course, between 2018, pre-pandemic, and then 2020. So this survey went out in late October of 2020. Those students that took that survey, they could have been anywhere between a freshman and a senior. So those first-year students would have missed their high school graduation, likely due to COVID, right? They would have then started college in an atmosphere very different than what they were always anticipating what their start of college would look like. Or if they were a sophomore or a junior or a senior student, they've sort of been robbed of some of that college experience, and how was that weighing on them, right? So the difference of students that reported that nearly every day for the last 2 weeks, they felt down and depressed, between 7% up to 11%. They felt nervous, anxious, or on edge from 13 to 17.8%. Those that were mentally exhausted from 13.5% to nearly 21.5%. And that, to me, that data point really jumps out. I gave birth to my third child on March 14th of 2020, and they shut down all the schools on March 16th, 2020, or March 17th on St. Patrick's Day, right? So I was on maternity leave during the very start of the pandemic, and I went back to work on Zoom calls, bouncing a newborn, right? And I remember that first week of Zoom meetings, and I have never been more exhausted in my life. I mean, the first couple of weeks of a newborn is a piece of cake compared to not having that oxygen that you get off of people in meetings, right? And I think all of us can relate to that, how all of that screen time, it is draining, right? So I think of these students that were trying to pivot, go to online learning, and then kind of being starved of their social life at the same time, being very isolated in residence halls, and then God forbid you test positive for COVID and you go into isolation housing, right? So it was a really difficult time to be a student in the fall of 2020, and it's still a tough time, and I'm so happy to see so many students here today. Then the numbers, of course, for the students that reported being very lonely nearly doubled. If we pan this out a little bit more, so these are the numbers that reported feeling this nearly every day for the last 2 weeks. If we pan it out, that did you feel this way around half of the time over the last 2 weeks, nearly all of these percentages jump up to the 35 to 45%. So this is the worst of the worst of how students felt. And if we really pan out, everyone's not doing awesome, right? The last couple of data points here, students who reported feeling this way fairly or very often in the previous few weeks, that they couldn't cope with all the things that they had to do. That to me is a very interesting data point, that it nearly cut in half from 38% down to 20%. Because now students had time. They're like, well, I'm not busy. I'm not going anywhere. So I could get all the things done that I needed to do. That not being able to stop or control their worry, that just weighs on my heart as well. 28% of students felt that way in 2020. And those that were bothered by their quality of sleep. Again, people not getting good rest. more than 2.5 times, from 10% to 26%. So this gets into our non-suicidal self-injury and suicidality data. When you look and compare our data to the K-12 system, our numbers are a little bit lower across the board, that going to college can be a protective factor for students that would be considering suicide. But we still, our numbers were fairly stable, but still trended upwards. Those that had suicidal thoughts, up to nearly a quarter of our students. Those that had a plan for suicide, around 9%, and those that had attempted suicide, around 3%. So what are we doing about this? In closing, we're doing everything that we feel that we can, but we know that we always can be doing more. And the only way that we know that we can be doing more is to hear from people, hear from our students, hear from our faculty and staff what it is that they need. So while counseling is still in demand, a lot of our counseling centers are pivoting. They're changing what they're doing. They're offering services in the residence halls at night. They're doing group therapy sessions. They're doing horse therapy. They're doing gardening classes. They're doing all kinds of things sort of outside the box to try to reach as many students as possible. We have a wonderful partnership with FirstLink. They provide all of our after hours coverage on the phones, which is so great. And so if a student calls in crisis and there's nobody available on campus, they will get automatically directed to FirstLink. And then FirstLink, in turn, if the student is in severe crisis, they will contact the on-call crisis coordinator on the campuses and try to triangulate services and help, which is just absolutely wonderful. This is a very strong priority of the State Board of Higher Education. And so they're trying to think of new ways. What other ways can we fund help, get more counselors, get more people in the counseling field? There's great programs through the ND Career Builders that if you choose to go into a field that's in high demand, you can get most of your student loans paid back. And so there's all different types of repayment programs to get people into these high demand fields. And of course, we're always continuing to survey our students, faculty, and staff, but what else can we do for you? What can we get moving and shaking? So that is the long and the short of it. I did my best to be 4 people up here today. I want to thank you so much for your attention, and have a wonderful day, everybody. Yes, is there a question? I barely, but yes. Well, I'll repeat it into the mic.
Can you hear me now?
Oh yeah, I can hear you now.
Awesome. We had a question from our online audience. They're wondering where they can get access to this information. And I believe that was specifically for the survey of college students, but I'm certain that other people would be interested about the YRBS as well.
Sure. I believe the YRBS data is all online on DPI's site. I could be making all of that up. That's a great question for Robin. Robin doesn't know either. But I think that the person could email you, and we can also turn in these presentations. This report, the ND swaps, it was posted online at one point in time, but I don't know if it is now. But I can get it posted online on the ndus.edu website, North Dakota University System. It's a little tricky because everyone wants to say NDSU, but it's ndus.edu. But we can also email it out to people. Any other questions? Oh, yes.
Just real quick, does that ND swap ever survey how much online time the students are doing? How much, what kind of lead going on?
So that's very interesting. So the question was, does the ND swap survey and ask students about how much time they spend online? So we're always trying to tweak the questions, but we don't want to ever change the survey too much, or else we'll lose, longitudinal and really looking at the bigger picture. One thing that we did ask was in previous years, we did ask a piece about social media and not so much about overall screen time and overall online learning time. And so there's a lot of different ways that students would categorize their online time. Much like when we found out, when we asked students, do you use e-cigarettes? They say no. But then you say, well, do you use a Juul? They say, well, yeah. And so they might not term a Juul as an e-cigarette, but so there's different ways that students want to define things. But that can definitely be something that we would add in the future, especially with misinformation and just how students take in information. Any other questions? You guys are listening. That's so fantastic. Thank you so much. All right, now who's up next? Is this Talk Saves? Yes, Talk Saves Lives. Do we have another break? Joelle? No? We're just rolling ahead?
Nope, we're just going to roll ahead. Yep.
We're going to roll ahead, and then after this, we have lunch. So thank you, everybody.